Hi, my name is Michaela Bennett. I'm going to be performing a presentation about obsessive compulsive disorder. First off, I want to apologize in advance. I've been having some sinus problems, so if my voice goes out or if I got a cough, bear with me. We're pushing through it. So let's get started. So obsessive compulsive disorder, what exactly is that? We hear people in public or on TV say, oh yeah, I've got a little OCD. Well, what exactly does that mean? OCD is an anxiety disorder, a psych disorder. There are two parts to this, as the name says, obsessions and compulsions. So obsessions are the recurrent and persistent unwanted thoughts or images that cause intense anxiety, specifically because they just keep coming, bam, 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 and there's hardly a way to get rid of them. So how do patients with OCD push through this? Through compulsions. These are ritualistic, repetitive behaviors that are performed to decrease anxiety or prevent a dreaded event, in their mind at least. So why is this a problem? Well, obsessions are excessive worries. They're not just the day-to-day worries that are there and gone. They are always present. And compulsions are only temporary escapes. The person with OCD often realizes this and knows that once they perform the compulsion, there's a little bit of relief, but then the obsession comes again. So they'd rather not perform the compulsion at all because of that, and also because they realize this is a little excessive. This might be a little unreasonable. I don't know why I'm doing this, but I feel like I have to, so here it goes. So they have a lot of feelings of disgust with themselves, doubt, and often fear. Fear because of an event that might occur, or fear that someone will find out about what they have to do to keep themselves going daily. So like I said, this is excessive, unreasonable, and oftentimes adults and children know this. They realize this, but they don't know how to function without performing these. This is very time-consuming. It interferes with their career, school, family, social, and daily activities. Emily Ford said this: it's like you have two brains, a rational brain and an irrational brain, and they're constantly fighting. So it's basically a tug of war going on. The destructive cycle of OCD begins with an obsessive thought here at the top. It goes down to anxiety, so this thought persists and you get anxious, more anxious, and then you have to do something to get rid of that anxiety. So it manifests itself in a compulsive act. And then after the act is done, there's a little bit of relief, but right after that relief, right back comes that obsessive thought again. So as you can see, there's not much peace involved. So approximately 1 in 100 adults in the U.S. have OCD. This means about 2 to 3 million Americans. 1 in 200 children have this. This is equally found in men and women, no preference gender-wise. In children, however, boys are more affected than girls, about a 2-to-1 ratio. Adult age approximates at 19 years old as the onset. However, there's also a pediatric OCD, and that approximate age is onset at about 10.3 years. There is OCD that becomes lifetime, that becomes chronic, and 2% of all cases in the U.S. are chronic or lifetime prevalence OCD. All ethnicities and races are involved, all cultures, no one's left out here. 50% of people with OCD do have another psychological illness. This could be an anxiety disorder, bipolar, schizophrenia, anything like that. A frequent combination that we see with OCD is actually Tourette syndrome, and it has to do with the way the brain is functioning. Eating disorders, substance abuse, and ADHD are also common comorbidities. Some risk factors. There's not a proven genetic factor. However, there is a higher prevalence among family members. If your mom, your dad, your sibling, your grandmother or grandfather, if anyone has OCD, you are more likely to have it as well. So religious groups or cultures, specifically, that place importance in any kind of washing rituals or maintaining healthy thoughts, those people are at risk as well, because they're focused on getting something clean, getting an object or hands washed before another ritual of some sort. Also, maintaining healthy thoughts. So if some unhealthy thing comes into mind, they push it away as fast as they can, but then if it comes back, they don't know what to do with it. Streptococcal infection is also a risk factor, surprisingly, and that's because it causes inflammation to the basal ganglia, and it can produce OCD. We'll talk about that a little bit more later. So some signs and symptoms. What we often see is washing or decontamination, a lot of Germ-X use, checking and rechecking things, repeating words, counting, and any behavior that is repeated in order to decrease anxiety caused by obsessions, or any situation that's avoided that triggers obsessions, is an OCD symptom. So we're going to go through some examples here of obsessions and then what that might manifest itself in a compulsion. So here we have fear of undesired events, such as a house fire. That might manifest itself in checking and rechecking the fire alarms before going to bed, checking all the electric sockets. Symmetry or keeping objects in line. That can be keeping pictures on the wall exactly 1 foot apart all the way up. Every picture has to be 1 foot apart from every other picture. And germs are everywhere, so don't touch a single thing. Keep your hands off anything, don't touch the doorknobs, don't touch the phones. Well, this can also compulse and show itself through the compulsion of washing and rewashing your hands or dishes. These are a couple pictures that remind me of OCD. On the left here you have this man who is not enjoying his alphabet soup. He's got to put it in order before he eats it. Then we have in the middle the hands that say wash me, constantly washing, scrubbing. You'll often see people with really red, dry, cracked hands. And then on the right you have Monk, which was a TV show of a detective who is very specific. He has a very unique case of OCD, not something that you'll find very often. Just a note, older children and adolescents may attempt hiding compulsions from their family because of feelings of shame or guilt. They feel like they're not supposed to be doing this, but they feel that they have to do this. And if they show it to anyone, if they let anyone know, those people will look down upon them as well. So some pathophysiological theories. Honestly, we don't really know what the specifics behind OCD are. However, we're going to go over some theories because there are many possible options out there. One theory is an increased activity of orbitofrontal cortex and basal ganglia structures. These structures, they all play a role in controlling reward and punishment related behaviors. They play a role in emotion, and they also play a role in subconsciously learning probabilities. Another theory is overactivity of direct pathway of the basal ganglia, and this would be seen in some of the above, what I just said there, in the behaviors and the emotions and the probabilities going on. Another theory is neurotransmitter dysfunction. You have abnormal dopamine levels, abnormal glutamate levels, and then abnormal serotonin levels. We know for sure that abnormal serotonin levels is somehow involved in OCD, but how, we're not quite sure. Some possibilities there's less serotonin in the synapses, hypersensitivity of postsynaptic serotonin receptors, or dysfunction in the genes encoding for serotonin transporter and serotonin receptors. So normal versus obsessive compulsive minds. Children with OCD versus children without do not have differences in memory, reaction time, or attention. However, the children with OCD do have deficits involving orientation, spatial perception, and the ability to learn by trial and error. Just something I thought you should know. This just shows a image of a PET scan. Here on the left you have the normal brain and the amount of energy that they use, and then on the right you have the obsessive compulsive, and you can see that all that red there, that's a lot of high energy, more energy utilized in the OCD. So diagnosis is really hard to come by sometimes. It's based on history and observation. They must have obsessions or compulsions for sure. There's no lab test or scans specific to OCD, so that's kind of what makes it a little more difficult to diagnose. It's also underdiagnosed in children, partially because they think this could be related to behavioral issues. It could be diagnosed as ADHD or some other behavioral problem, because the children aren't able to focus on what you want them to focus on. They're focused on the specifics of trying to get everything else in order. for a diagnosis of OCD, this needs to cause some serious distress to interfere with daily life, taking more than an hour per day to satisfy obsessions or compulsions. Except for children, the individual must realize that these thoughts and feelings are unreasonable or excessive. And the reason children are left out is because they might not have the cognitive development yet to understand this. There's also another little subgroup of OCD, and it's called poor insight. And this is basically a category of a person with OCD who's unable to recognize that their behavior is illogical. It doesn't make sense. It's less resistant to obsessions because they don't understand why they should stop. So then they're not gonna stop. Some therapeutic interventions include behavioral therapy, exposure to the feared situation, and prevention of compulsive behavior. Oftentimes, children benefit most, especially ones that have mild to moderate severity OCD and want to stop. Cognitive therapy is another type. It basically challenges the maladaptive thoughts that are had. And then family therapy, especially utilized if OCD disrupts family roles. There's medicinal intervention. SSRIs is the first-line therapy. A higher dose is often necessary than for depression. And then 50 to 60% there's a positive response for OCD. Then you have a tricyclic antidepressant, clomipramine is the second line. And then if OCD is severe enough, an atypical antipsychotic is necessary. The most common drugs are fluoxetine, sertraline, paroxetine, citalopram, and clomipramine. Other medications, though, include benzodiazepines, serotonin, which makes sense because if there's a decrease of the serotonin that we need in the brain of an OCD patient, then you're going to give them serotonin. And then also the norepinephrine reuptake inhibitors. However, as we were talking about earlier, if the streptococcal infection causes the OCD, antibiotics should stop them if those symptoms are caught soon enough. If not, they may have to go on an SSRI or another drug. Surgical intervention is also possible. This is only if there's a failure to respond to medicines and therapies. Two surgeries are the anterior capsulotomy, which is basically making a cut in the internal capsule portion of the brain, and that just helps with the regulation of the pathways. And then also the deep brain stimulation. However, efficacy and safety is very controversial with these because it is in fact a brain surgery. So the best treatment for OCD is cognitive behavioral therapies, the combination of cognitive and behavioral. This is the therapy of choice for OCD. It's used by many psychiatrists. This involves exposure to a stimuli, an anxiety stimuli, and then the response prevention. So for hand washing, an example is the patient might have to go around and touch doorknobs and handles and telephones and go through daily life and not wash their hands or decrease the amount of hand washing they do. SSRIs, medication and therapy has to be together. If you only have medication or therapy, the results are not nearly as successful. And then just some things to remember for as nurses and as people that may come into contact with OCD patients, effects of medication take several weeks to begin. So once they start a medication, don't expect it to take off like crazy. It'll take a little bit. If the medication is stopped, there is a 24 to 89% relapse. This is so vast because depending on the type of therapy, the type of environment they're in, also depends on the type of medication. Be patient. Allow some compulsions. It's hard as nurses and as healthcare workers. We don't want them to go through this. So we're like, no, stop. But really, they need to release some of their anxiety. Let them do a little bit of compulsing. It's okay. And then we'll focus on how we can help them through the rest. Also, parents specifically create a kind, encouraging environment for the children. They don't need to be looked down upon. They feel like they already are being looked down upon. So just be encouraging. Help them through this. This is just a picture of what OCD patients feel like sometimes. It says, I have CDO. It's like OCD, but all the letters are in alphabetical order, as they should be. And these are my references. I hope you guys have enjoyed my presentation, and I hope this kind of helps you understand a little bit more about OCD and how you can help your patients with OCD. Thank you.